Yes, I didn't see. And now we proceed to the last already announced presentation of Dr. Nachira about the multi-center Italian study on robotic surgery for large thymoma patients, oncological outcome.
Good afternoon, dear colleagues. Sorry, but they are having some problems in uploading my lecture. Okay. We don't know why. I would like to thank you, first of all, the ESTS Society for this great opportunity for being here and the chairman for the introduction. I have no disclosure. As everybody knows, minimally invasive surgery, and in particular robotic-assisted thoracic surgery, is still considered a challenging procedure, above all in case of large mediastinal anterior mass, like large thymomas defined according to the literature as a tumor with a measured diameter of more than 5 centimeters. Due to the possible difficulty in handling the lesion, in dissecting from surrounding structure, and in the potential risk of rupture of the capsule and spreading of the tumor. That's why in the literature are available very few studies and very few series of reports with small data and a few conclusions about this topic. Therefore, the main aim of this study was to evaluate surgical and oncological outcomes on rat thymectomy in the treatment of larger thymomas. Clinical data of 318 thymectomies for thymoma with concomitant or not myasthenia gravis performed in 7 Italian high-volume centers from 2010 to 2023 were retrospectively reviewed. The inclusion criteria were thymectomy for pathological proven thymoma in myasthenic or not patients, performed by open RATS or VATS approach in nodule patients who signed informed consent, while the exclusion criteria were patients affected by thymic carcinoma or benign thymic disease, patients judged not resectable during surgery or lost at follow-up. This is the list of the 7 centers involved, part of our centers gemelli in Rome, 2 centers in Milan, then Bologna, Bari, Verona, and Monza, that we thanks. Surgical outcomes were evaluated first in a RATS group per thymoma size, so for small thymoma with a diameter less than 5 centimeters and for large with a diameter measure equal to 5 centimeters. Then in a large thymoma group per surgical approach, RATS versus open and RATS versus VATS. Then in Kaplan-Cox regression analysis were used to identify any prognostic factors for oncological outcomes in larger thymomas and to reduce any potential bias related to the retrospective nature of the study. A one-to-one propensity match score analysis was performed for the larger thymoma group of RATS and open surgery for the following variables: sex, BMI, myasthenia gravis, comorbidities, pathological Masaoka stage, histotype according to the WHO classification, adjuvant therapy, and thymoma diameter, and then surgical and oncological outcomes re-evaluated in the match groups. These are the characteristics of the whole population. The mean age was 59 years with about 37% of patients with concomitant myasthenia gravis and the mean thymoma diameter of 6.27 plus minus 2.94 centimeters. Evaluating the surgical result for RATS group for small and large thymoma, we can see as basically the characteristics of patients, clinical characteristics were comparable except for a higher number of myasthenic patients operated on in smaller group and for a higher use of right approach in the larger thymoma. And about surgical results, we recorded the same number of postoperative complications, except for a higher number of minor complications in the small thymoma groups and higher use of adjuvant radiotherapy in the small thymoma group. For surgical outcomes, we compared RATS and open approach. Clinical characteristics, as you can see, were comparable except for larger thymoma diameter, obviously in the open surgery, with higher pathological Masaoka stage and higher use of adjuvant therapy and extended resection in the open group, with higher and significant higher minor complication, major complication in the open approach, and the longer in hospital stay and chest tube length. While comparing surgical outcomes from rats and bats group, both groups were comparable for clinical characteristics and surgical exact, but an interesting data was that no myasthenic patient was operated on by bats approach. Evaluating the oncological outcomes in terms of 5-year overall and disease-free, so 5 and 10 year overall and disease-free survival, both group of rats and open surgery operated for a large thymoma were comparable. And at multivariable analysis, the only prognostic factor affecting the overall survival in the large thymoma group was age over 60 years, while the only prognostic factors at multivariable analysis affecting disease-free survival was the adjuvant radiotherapy. Then, a propensity match analysis was performed to reduce the biases related to the retrospective nature of the study, obtaining 50 patients per open group, 50 patients for rats group of large thymoma. At this point, as you can see, both groups were comparable, and surgical results about longer chest tube length and hospital stay were confirmed being higher in the open group. Reevaluating also the oncological outcomes at multivariable analysis, no prognostic factor was confirmed, while the only prognostic factors affecting disease-free survival was the adjuvant radiotherapy, not the surgical approach. In conclusion, with the limit related to the retrospective nature of the study, rat surgery for large thymoma is an effective and approach treatment for treating this type of pathology, with the shorter chest tube length and shorter in hospital stay compared to open surgery, but with the same oncological outcomes in terms of overall free survival and disease-free survival. And adjuvant radiotherapy, not the approach, was the only independent prognostic factors affecting disease-free survival in the group of large thymoma at multivariable analysis after propensity match score analysis. Thank you, and I would like to thank you again all the centers involved in this study.
Questions from the floor to Dr. Nachira? I would ask, what do you do with the result for your clinical decision-making? Would you recommend to do it possibly by video-assisted non-robotic surgery for the larger thymomas now?
No.
Because there's no difference. And second question, what is your comment on the radiotherapy factor?
Thank you for the questions. About the first questions, as you can see, we compared the rats with the VATS approach only before matching the analysis, and the VATS population was very, very small population of few patients, and as you can see in the first wool table, the type of VATS approach, half approach was conducted also bilateral for managing this huge mass and in no myasthenic patients. So I would not recommend the VATS approach for large thymoma, but better VATS approach in centers that had experience with the robotic surgeries. Otherwise, I recommend to prefer the open approach. And about the significant role of radiotherapy as prognostic factor for disease-free survival, I think is related to the fact that is in this type of epithelial tumor, as you can see from the population involved, the type of histotype was A, B, but a lot of patients also B1 and B2. The higher population was Masaoka 1 or 2, and there was also patients operated on with microscopic invasion of the capsule, so 2A. And as reported, few people, also about the 5-6%, both in open and rats group after matching, as not only NR0 radicality but NR1. So that's why this data can explain the prognostic factor of adjuvant therapy. So it means that radiotherapy is the prognostic factor just because involved other factors behind, like the pathological stage and the possibility of invasion of the capsule of the tumor. This is the explanation that I have.
And what do you think is the limit? I mean, of the tumor diameter to resect by any method? I mean, any non-open method.
Non-open method, yes. It's obviously difficult to manage a large tumor. We spoke about a diameter more than 5 just because in literature large thymomas are defined this way. We tried also to, because we evaluated the diameter as you see, as
10 centimeters or?
we evaluated like a continuous variable, but I performed a subgroup analysis that I didn't report with a cutoff of 7 centimeters because in rats group, as you can saw, the mean diameter was about 7 centimeters, not more, and the median was 6.5. It means that some lesions higher were managed by rats approach, but was not we don't use to do because it's difficult to manage the other side, and above all, you have to be very, very practical with this technique to visualize the contralateral phrenic nerve and to visualize the structure. You need to be expert to perform larger lesion.
Thank you.
Thanks very much.